Good morning, everyone. I have the privilege of being the first of the hepatology speakers today, and I'm going to be talking to you about hepatitis hot topics and discuss updates in hepatitis B and hepatitis C. Two topics so the post-DDW abstracts with liver, and in particular hepatitis B and hepatitis C, I have to tell you there is nothing markedly dramatic and new. So I chose some abstracts that just allow me to speak upon a couple topics that I think are important for a general GI audience to review. But remember, none of this is brand new data, but I think still important to focus on. So the first thing I'm going to talk about is hepatitis B reactivation when you use IBD immunosuppressive therapies with your GI patients. What should you be screening with, and what should you do with those results? First, I thought it'd be important to review some terminology, a little refresher about hepatitis B. Overt, chronic, active hepatitis B infection refers to people with positive surface antigen. Occult or resolved infection refers to patients with surface antigen negative serologies, but their core antibody will be positive. And this indicates that they have prior exposure and not currently infected. Remember, hepatitis B is different than hepatitis C. You're never really cured of hepatitis B. It always exists in your covalently closed circular DNA in your liver. So when you immunosuppress them, whether that's with bone marrow transplant, chemotherapy, or even IBD immunosuppressive therapies, there is always a chance of hepatitis B reactivation, even though currently they have no evidence of active infection or viremia. So the prevalence of hepatitis B infection amongst IBD patients is actually not very high. Those that have overt infection, meaning surface antigen positivity, is less than 1%. Those that have so-called resolved infection with core antibody positivity is less than 10%. But hepatitis B reactivation from IBD immunosuppressive therapies have been associated with liver failure and death, so it is important that we recognize, screen, and treat if needed prior to starting your IBD therapies. So this is an abstract, hepatitis B reactivation in hepatitis B virus-infected patients with IBD receiving anti-TNF therapy. Again, not a new story from DDW, but worth reviewing. So I wanted to focus on how do you screen for hepatitis B, and what do you do with these serology results if you plan to treat your IBD patients with immunosuppressive therapies. So AASLD and AGA will recommend that you order 3 tests prior to starting them on IBD therapy: surface antigen, core antibody, and surface antibody. But now that you have these results back, how are you going to interpret them, and what are you going to do with them? So if the patient is surface antigen negative, core antibody negative, this person is not infected, you should vaccinate them, and then you can proceed with IBD therapy. Now, if the person comes back surface antigen positive and core antibody positive, this person has overt chronic active infection. You do need to check a baseline hepatitis B DNA. You should start all of these patients on hepatitis B prophylaxis with entecavir, tenofovir, or TAF, which is the new formulation of tenofovir, also called Vemlidy. Ideally, you should start it a couple of days before immunosuppression, but at least at the start of their IBD therapies, and you should continue it for the duration of their immunosuppression and for 6 months after, because there is risk of reactivation even after you stop the therapies. And of note, there is no prophylaxis needed for Imiran 6-MP methotrexate if you're using it alone. This population is a little bit more challenging. So this is the surface antigen negative, the core antibody positive patients, the so-called, again, occult or resolved infection. These people do not need therapy. They should be monitored. You do need to check their DNA and their LFTs every 1 to 3 months, maybe more like 1 month in the beginning of therapy, and as they've been on it for months and certainly even years, you can open it up to every 3 months. AASLD also adds to check a surface antigen. There is a rare incidence of seroreversion, meaning you were surface antigen negative at one point and become surface antigen positive. AGA also is more specific about prednisone. AASLD does not specify this, but AGA does say that you should consider prophylaxis in these core antibody positive patients if you're using long-term and what they call moderate to high doses of prednisone, which is basically anything greater than or equal to 10 milligrams for over 4 weeks. But they do specify if you're using low-dose long-term prednisone, prophylaxis is not needed. So back to this abstract, hepatitis B reactivation with anti-TNFs was a retrospective multi-center study from Asia. They did look at surface antigen positive patients as well as core antibody patients. There was 109 of them. Most of them had Crohn's, and 80% of them had chronic hepatitis B infection, meaning surface antigen positive. Remember, this is an Asian country. That prevalence is much higher than it would be here in the US. And they were followed for almost 2 years. The incidence of hepatitis B reactivation amongst chronically infected surface antigen positive patients was 15% and 0% amongst those with resolved core antibody positive hepatitis B infection. And this part of the slide emphasizes that amongst those who reactivated with chronic hepatitis B infection, there was a statistically significant difference in reactivation amongst those who were prophylaxed with Hep B medicines prior to therapy as opposed to not. I think that's obvious, but this slide just emphasizes that. Most of those patients were able to be easily managed in terms of virologic response by adding or changing antiviral therapies. Some had to discontinue the IBD therapy. And of note, the antivirals did not seem to affect the IBD course of those patients. So I'm also going to talk about a similar phenomenon that has been a little bit more recent given the new approval of all of our various DAAs. So this is hepatitis B reactivation with our new hepatitis C direct-acting antivirals. So the prevalence of hepatitis B amongst those with hepatitis C, so this is co-infection. For chronic hepatitis B infection, again, this is surface antigen positivity, not so high, 1.5 to 6%. The resolved hepatitis B infection, meaning core antibody positive, is much higher. Remember, there's many shared transmission risk factors with hepatitis B and hepatitis C, so that range is anywhere from 35 to 62%. When you have co-infection, there's always one virus that's dominant, and that's usually hepatitis C. So you may not, even if you test them for viremia, hepatitis B may be suppressed. You won't see it. One is always going to be dominant over the other. But what we have found is that once you eradicate Hep C, it allows hepatitis B to replicate and reactivate. So much so that the FDA put out a black box warning on all of the DAA labels, directing providers to make sure that they are looking for hepatitis B because it has been associated with fulminant hepatitis, hepatic failure, and death. And so ASLD, EASL, and IDSA, which is the Infectious Disease Societies of America, have put out recommendations that we must screen all hepatitis C patients prior to DAA therapies for hepatitis B. And you need to order 3 tests, which is surface antigen, core antibody, and surface antibody. So the incidence rate of hepatitis B reactivation is still pretty rare. This is a study that looked at over 62,000 vets from, with the VA system, who underwent DAA therapy. They defined hepatitis B reactivation as greater than 1,000 IU per ml increase, so a 3-log increase in hepatitis B DNA, or seroreversion, meaning change from surface antigen negative to surface antigen positive. So amongst those with chronic surface antigen positivity, reactivation was about 2%. I put a little asterisk there to remind me that there were some limitations in the study that probably underestimated this. And the rate of reactivation amongst resolved hepatitis B infections, that's core antibody positivity, was very low, essentially 0. So back to the abstract, sorry. This is looking at reactivation amongst patients undergoing DAAs. So there's 194 patients treated with DAAs that had chronic and resolved hepatitis B infections. Of the 24 with chronic, meaning surface antigen positivities, 29% reactivated, and they appeared to be clinically significant with elevated LFTs. Of the 170 patients with resolved core antibody positivity, only 2% or 2.3% reactivated. But again, whether this is clinically significant isn't known. All of their LFTs remained completely normal. SVR was still high amongst this group at 94%. So I thought it'd be important kind of to summarize what you should do with these serologies again. First, you do need to test them. You absolutely mandated to test surface antigen, core antibody, and surface antibody in all patients before you start them on DAAs. If their markers come back negative for all 3, again, just like the other group, you're going to vaccinate them and you can proceed with DAAs. Now, the group that is surface antigen positive sorry about that, surface antigen positive, but with a markedly detectable DNA, AASLD will recommend that you treat them if they meet criteria, so-called criteria. Criteria defined by the AASLD is if your DNA is greater than 2,000, you should start them on hepatitis B antivirals prior to DAAs. However, if you're surface antigen positive with a low, meaning less than 2,000 international units per ml, or even an undetectable viral load, AASLD will say you do not need to start them on prophylaxis. They will say that you should monitor them with a DNA and LFTs every 4 weeks during DAA therapy and continue it for 12 weeks after completion of DAAs, meaning essentially you can stop when they get their SVR12 labs. However, there has been a lot of data showing that reactivation occurs even in patients with completely undetectable viral loads prior to DAA therapy. So in my practice, if I have a surface antigen positive patient and I'm starting them on DAAs, regardless of what their DNA level is, even if it's undetectable, I will start them on prophylaxis. The chance of reactivation always is low, but can be devastating. So I think there's enough data to show that we should maybe question the AASLD recommendations. This last group is the so-called resolved hepatitis B infection patients, core antibody positivity. They do not need prophylaxis. You can just monitor them. So in summary for the hepatitis B part, hepatitis B reactivation with IBD therapy, you're going to order 3 tests, just like with the DAA, surface antigen, core antibody, and surface antibody. Of those with chronic infection and surface antigen positivity, you are going to start them on prophylaxis for during their IBD immunosuppressive therapies and continue it 6 months beyond when you decide to stop, if you decide to stop. Those with the resolved hepatitis B infection, core antibody positivity, you do not need to prophylax them. You should just monitor them with LFTs and DNA every 1 month in the beginning, and then certainly you can open it up to every 3 months once they've been on stable immunosuppression. So for those with hepatitis B reactivation and DAA therapy, again, there's a black box warning. You must check for surface antigen, core antibody, and surface antibody. If they come back surface antigen positive, it's up to you. Again, these guidelines I find a little questionable. If they have high level of viremia, you absolutely must prophylax them prior to the DAAs, and you can probably stop it at their SVR12 labs. If their viremia is low, AASLD will say you can monitor them. Again, it could be wise to consider prophylaxing them even if they have undetectable or low-level viremia. If they have resolved infection, meaning core antibody positivity, and they're undergoing DAAs, you can monitor them and just get labs frequently during DAA therapy. So now I'm going to switch gears a little bit to hepatitis C. I thought I'd focus, again, like hepatitis B, with DDW, there wasn't brand new DAA therapies that were introduced. So I picked a couple abstracts that allow me to speak upon some difficult to treat populations, and as well as to discuss a little bit about some controversy about whether DAAs can actually increase your risk of HCC. So I'm going to start with looking at retreatment of hepatitis C DAA failures. I'm going to do a couple of cases. So this is a 45-year-old gentleman. He has compensated hepatitis C cirrhosis, genotype 1B, and he was a treatment failure to Epclusa for 12 weeks. What should you do? Because, of course, he wants to be retreated. So this slide is just a reminder of the DAA, which is the direct-acting antiviral targets. We are looking at different proteins and targeting those proteins that are involved with viral replication and assembly. The NS5A inhibitors end in usvir. The NS5B polymerase inhibitors end in buvir, and the PIs end in previr. I do not expect you to remember this, but at least I figured you should see them and understand their names and maybe be able to start categorizing them a little bit. So this, if you have not used this website, I want to make sure if you get nothing else out of my talk, please remember this website, hcvguidelines.org. It is a wonderful point-of-care website set up by the AASLD and IDSA to help you when you have a patient, in terms of determining which regimen would be appropriate and what the level of evidence is to support it. So for instance, if I have a treatment-naive genotype 1A patient with compensated cirrhosis, this website will tell me all the various different regimens that are approved and recommended, as well as alternative, meaning, that has been used in the past, but we don't really recommend it. So all that data is there. It'll tell you the duration, as well as the strength of the evidence to support those recommendations. So our gentleman, again, he is a treatment failure to Epclusa. I wanted to introduce you to a term called NS5A inhibitor experience. The reason I want you to be aware of it, it is in the hepatology literature. The HCVguidelines.org website will label these people, so I might as well explain and make sure you're comfortable with this term. Remember, the NS5A inhibitors are the ones that end in a sphere. But the bottom line is basically all of the new DAAs contain an NS5A. So if you've been exposed to Mavyret, Vosevi, Harvoni, Epclusa, declatosphere, sabosavir, Zapadier, Vicurapec, you are considered NS5A inhibitor experience. So when you see that in the literature or in recommendations, just know that's basically anyone who's been treated with a DAA. So again, back to our website, gentlemen with genotype 1 NS5A inhibitor experienced, this is what you would be treating them with: Savasvir, Velpatasvir, Voxilaprevir for 12 weeks. And I want to point out that this is a pan-genotypic regimen. So bottom line, if you have someone who's failed a DAA, it does not matter what genotype it is. It does not matter if they have compensated cirrhosis or not compensated cirrhosis. You're going to treat them with Vosevi. And so for this gentleman, it's 12 weeks, regardless of genotype. Back to this abstract. So there, again, these are not cutting edge new information. This is just an abstract that looked at phase 3 data for Sofel-Vox for 12 weeks. And remember, this medicine was approved almost a year ago. So this was a retrospective review of 454 patients, again, phase 2, phase 3 data for Vosevi. 41 of them had compensated cirrhosis. SVR was great, 97% overall. Adverse events, headache, fatigue, diarrhea, and there were no SAEs. So in conclusion, the authors presented that Vosevi is safe, effective for your NS5A inhibitor experienced patients. So back to our case, this gentleman has compensated hep C cirrhosis, genotype 1B, failed Epclusa. What would you treat him with? You would treat him with Vosevi for 12 weeks, and you can tell him this will offer him an SVR rate of approximately 97%. So to add a fun little twist, I thought I'd say, well, what if we had the same gentleman, but he had decompensated? So he has a child B or child C cirrhotic. Of course, please remember, maybe this person should be considered for transplant. That should be your first thought prior to treating them for their hepatitis C. But if for some reason they're not a transplant candidate, perhaps they don't have adequate social support, if you do choose to treat, remember you cannot use protease inhibitors in decompensated cirrhotics. So basically you cannot give them Vosevi, which contains a PI, and I put the list of the PIs in that little box on the side. So your options would be Epclusa or Harvoni plus ribavirin, which remember in this group you'd have to be very careful about a hemolytic anemia developing, and you'd have to treat him for 12 weeks. Okay, so the next difficult to treat population would be those that have CKD and end-stage renal disease on dialysis. So similar case, 45-year-old gentleman, compensated hep C cirrhosis, he's treatment naive, genotype 1B, and he's on dialysis. How could you treat him? The controversy was really sabosavir is renally excreted, and so there is unclear safety in patients whose GFR is less than 30. So regimens that contain sabosavir really shouldn't be used in patients that have CKD or on dialysis. So HCVguidelines.org will tell you if you have a patient with advanced kidney disease, your options are going to be elbasvir, grazeprevir, which is Zapadier, for 12 weeks, but that's only for genotype 1 and 4. So more recently last year, the FDA approved glecaprevir and pibrentasvir, which is Mavyret. And again, this is pan-genotypic for 8 to 16 weeks. So now our patients with chronic kidney disease and end-stage renal disease have two options based on genotype. So this abstract looked at the, again, not new data, but this looked at the phase 3 data for glecaprevir, pibrentasvir, which is Mavyret, in renally impaired patients with chronic hepatitis C, genotype 1 to 6. There was 101 patients. 13% of them had compensated cirrhosis. 73% of them were on dialysis, and they received varying therapies of Mavyret. Side effects were mainly pruritus. There were no SAEs. Prelim SVR was 100% in this previously difficult to treat population. So again, in conclusion, Mavyret, which is already FDA approved, is safe, effective for patients with CKD and end-stage renal disease on dialysis. So our gentleman with compensated cirrhosis and end-stage renal disease, you would treat him with Mavorite for a total of 12 weeks. As a disclaimer, you could also use Zapadier since he's genotype 1. And again, a little twist on the same situation. What if this patient had end-stage renal disease but did not have cirrhosis? He could get Mavorite for only 8 weeks. Okay, so I'm going to switch to my last topic, which is looking at DAAs and its potential risk for increasing HCC. So in 2016, this controversy began. The DAAs are coming out. We're seeing amazing SVR rates. Nobody's seeing a downside to curing hepatitis C. And then one of the large groups known for many of their rigorous and great studies on HCC in Barcelona found some data that showed that there was an increased risk of HCC recurrence after SVR. So these are patients previously treated for the HCC in clinical remission for a period of time, treated with DAAs for hepatitis C, achieved SVR, and they found recurrence rates of 28% amongst their different population, again, at a very reputable center, and 28% is really quite high. It hasn't really been replicated elsewhere. There's been additional larger studies that actually show a decreased HCC recurrence after SVR. So it has been a little bit confusing, but this worried many of us in terms of using DAA in our HCC patients. So this was an abstract from DDW that looked at the risk of HCC recurrence. Again, these are patients that already had treated and remission HCC in HCV patients treated with DAAs in a US veteran population. There was 264 veterans with Hep C, and again, their HCC was treated. They were in complete remission prior to the initiation of DAAs, and DAAs were started actually quite late, so they were in remission for quite a long time, median of 30.9 months after their last HCC treatment. And then recurrence occurred in 26.4% of patients over a median of 23 months of follow-up. And this study found that SVR was actually associated with a decreased risk of HCC recurrence, and this is obviously a larger data set than that from Barcelona. And what they found that was interesting was the risk of HCC recurrence decreased with a longer duration between when they were in remission and starting their DAA. So it seems that maybe there's a time-sensitive aspect of HCC recurrence, and maybe waiting from the time of remission to starting DAAs may be a good idea. So I wanted to also talk about what about patients who don't have HCC already? Are they at risk of developing HCC if you treat them and cure them with the DAAs? So there was one small study that was just sort of an editorial to Gastro when they discussed their experience with 66 patients who underwent DAAs, and 9.1 of them developed new HCCs, and they were pretty advanced HCCs, immediately within 6 months after SVR, and they found this very concerning. So there was, of course, other studies that tried to see if this was actually true, and there's a large VA study with over 22,000 vets who underwent DAAs. 271 of them developed HCC, and they actually found the opposite, that if you cure them of their hepatitis C, you reduce their risk of developing a new HCC by 72%. And then also important to note is that if you had cirrhosis, you cure them of their Hep C, they get SVR, their risk of developing HCC does not become 0. It's less than if they hadn't been cured, but 1.82% of them still developed a new HCC. So please remember, if you cure someone of their Hep C and they have cirrhosis, you cannot stop screening them for their HCC with ultrasound and AFP every 6 months. So in summary, hepatitis C is very curable nowadays, even in populations that previously were very challenging. If you have a NS5A inhibitor experienced patient, you're going to treat them with Vosevi for 12 weeks. And remember, this becomes simple for us as hepatologists and gastroenterologists. If you have a DAA failure, regardless of their genotype, you're going to treat them with Vosevi for 12 weeks, and that will give you an SVR of 97%. What about the patients with advanced kidney disease and end-stage renal disease? We have a treatment regimen for you. Mavorite for 12 weeks, again, does not matter what genotype they are. You're going to give them an SVR rate of 98%. SVR from DAAs, I think we've hopefully settled this controversy about HCC a little bit more. It does not seem that curing your patient of hepatitis C with your DAAs will increase their risk of HCC recurrence. In patients with HCC, maybe it is wise, though. Obviously, you're going to defer their Hep C treatment and prioritize their HCC treatment. That just makes sense. Treat their cancer first. But perhaps it is wise, after you put them in remission, to wait. Again, maybe about 6 months is reasonable, and then start them on DAA therapies. Also, it seems that SVR from DAAs does not increase your risk of developing a new HCC, and in fact, probably significantly reduces your risk of developing a new HCC. Thank you very much.